have such a full house today. I'm really excited you chose to be here. This is Health Equity for People with Disabilities at the World Health Summit 2024. Now I want to talk about communication. Traditionally, we're told that to listen, you have to sit still, be quiet, and listen with your eyes. But not everybody listens that way. Some people listen with their ears. Some people are not comfortable making eye contact or can't make eye contact. Some people need to move and stretch to process what's going on. So we are going to role model accessibility, and you do what you need to do to feel comfortable listening. And if you need to get up and leave the room to go to the restroom, this is being recorded, so you can catch the rest later. My name is Haben Girma. I'm deaf-blind. I have limited vision and hearing. My older brother is also deaf-blind, and he grew up in Eritrea. And the doctors told him, we can't help you. And the schools told him, we're sorry, we can't help you. And my parents were very worried. What can we do for a deaf-blind child? I was born in California. And when my parents found out I was blind from the doctors told them, don't worry. She will find other ways to do things. She can learn to read Braille. She will get a white cane or guide dog. She will have teachers instructing her, and she can do anything she wants to do when she grows up. And getting that kind of message from our healthcare system was profound for my parents. And my older brother also soon got access to assistive technology, training, sign language. In the United States and around the world, that is very rare. Most doctors just feel uncomfortable or don't know all about disability culture, like how to schedule sign language interpreters for visits. How do you weigh someone who uses a wheelchair? Those are things a lot of healthcare systems struggle with. And today we're going to talk about how do we get to the dream where everyone has access to healthcare, whether you're disabled or non-disabled, whether you live in Eritrea or the United States, you should all have access to healthcare. I got really good access to health and school and graduated from Harvard Law School as their first deaf-blind student. I worked as an attorney, and we sued some hospitals that were discriminating against disabled people. So it's a civil rights issue. And I'm now a commissioner with the World Health Organization Commission on Social Connection. Part of health is access to connection, community groups, communication access. And for this presentation, I am using a Braille computer and keyboard. I will read what speakers say in Braille. My typist is typing that. And you will notice a delay between when someone speaks and when I respond. That's because the communication is coming through. Part of accessibility is patience. Make time for different kinds of voices. Voices that speak, voices that sign, voices that use assistive technology. So we need to change our cultures at our health systems, at our medical schools, so that we're training doctors and care providers to treat disabled people with respect and make sure we have equal access to healthcare. We have a lot of amazing speakers today. Our first one is Dr. Jerome Solomon. He is Assistant Director General for the World Health Organization. Dr. Solomon, the lectern is yours.
First of all, thank you. Thank you very much, dear moderator, dear Haben, for your inspiring words. Your Excellency, Ambassador Smith, Deputy Permanent Secretary Rumatila, dear colleagues and friends, good afternoon. It's a real pleasure to be here with you today. I would like to thank all the partner co-hosting organizations, Sightsavers, International Disability and Development Consortium, Clinton Health Access Initiative, Special Olympics, the Missing Billion, and the London School of Hygiene and Tropical Medicine. It has been a great collaboration to organize this event together. My presence here demonstrates the importance of this agenda for the World Health Organization. Just now, in the very next room, our Director General, Dr. Tedros Adhanom Ghebreyesus, is speaking at the Women Leadership and Trust event, mentioning the importance of health equity for women and girls with disabilities. Today is the first time that an event entirely focused on health equity for persons with disabilities is held at the World Health Summit. It's our hope that this will not be the last, and that health equity for persons with disabilities will be featured in future World Health Summits. This is important because we know that compared to the general population, persons with disabilities die up to 20 years earlier and have poorer health due to unjust and avoidable factors. But the health sector is not addressing these health inequities, and persons with disabilities are left behind, as we show in our global report on health inequities for persons with disabilities. The good news is that we know what to do, and we have already outlined it in the global report. Targeted disability inclusive actions as part of our primary healthcare efforts and as part of every country's journey towards universal health coverage is what is needed. Advancing disability inclusion in the health sector is not a choice anymore. There are 1.3 billion people with significant disability in the world, and we know that investing in disability inclusion in the health sector has benefits for the economy and society. WHO estimates that every US dollar spent on disability inclusive non-communicable disease prevention and care yields 10 US dollars of increases in healthy life years and human capital. WHO is aware of the importance of making good investments. Tomorrow, the Director General, Dr. Tedros, will be speaking on WHO's investment round to encourage and secure funding for WHO to support countries to address global health priorities. Our investments need to be smart ones, ensuring everyone has equitable access to healthcare, including persons with disabilities. WHO is moving the disability inclusion agenda forward in 3 key ways. First, WHO is bringing stakeholders together under a common vision for coordinated action towards health equity for persons with disabilities. This will be done through our new Global Health Equity and Disability Platform to be launched in 2025. In fact, just in the last 2 days, we held the first global consultation meeting here in Berlin with experts working in the disability and health space. Second, we are mainstreaming disability in our own house through the implementation of the United Nations Disability Inclusion Strategy across our business operations and technical programs. Third, WHO is supporting ministries of health to develop national action plans to advance disability inclusion in the health sector through the WHO Disability Inclusion Guide for Action, a planning tool that will be launched soon. However, WHO cannot do this alone. Every stakeholder has a role, and listening to and acting on the voices of people with disabilities is fundamental, I thank the International Disability Alliance for its close collaboration with WHO, and of course, the heavy lifting on health equity for persons with disability should not be left to the NGO sector only. All stakeholders share this responsibility, which makes this event during this World Health Summit so important. If we want to achieve health for all, we must prioritize health equity for persons with disabilities as part of the global health agenda. We look forward to continuing to work with you. Thank you so much.
Thank you, Dr. Solomon. We now have with me here, to my right, Rachel Balcom from Suriname. She is the Special Olympics Health Messenger. Can you introduce yourself?
Yes. Can I speak? Okay.
Go for it.
Yes. Before I begin, I have some pictures, so that to remember me that when I'm talking with through it. Okay. Yes. My name is Rachel Veldkamp. I'm from Suriname. When I was young, I found out I have an intellectual disability. I also found out that I love swimming. I want to. Sorry. I went to a special school where my sport teacher told me about the Special Olympics. I compete in swimming for 15 years, and I won 95 medals. Besides swimming, I have a small business where I work with wood and painting because I enjoy working with my hands. I work to earn money for my health and to take care of my house. Yes. I got married 3 months ago, and now my husband and I pay for our health, and for our health and bills together. I'm also a healthy messenger for Special Olympics Suriname. As a health messenger, I teach other athletes like me about health, about healthy eating and exercises. Today I'm here to speak about the needs and the rights of people with intellectual disabilities, it's called IDD. This next slide.
That was fantastic. You shared, you found one of your passions, swimming. You found joy through creating with your hands. And you found love. Congratulations on your recent marriage.
Thank you.
A lot of people in healthcare assume that disabled lives are worse than they actually are. A lot of people wonder, can disabled people be happy? Can disabled people have relationships or jobs or swim? And you were teaching us a lot that we can do things if we're supported. And I don't know a lot about Suriname.
Mm-hmm.
Can you share a story about what it's like trying to get health care there?
Yeah. Yes, being healthy is very important. It's like having a strong body. If you want to be a great athlete, you need you need a strong body. It's hard to play sports or do your best if you are hurt. Exercise is important for good health. I once got hurt while training. my back hurts a lot and didn't go away. I went I went to go to the doctor and she gave me medicines and told me to to do exercises. It's called physiotherapy. Um, but the sessions were too expensive and I couldn't pay for them. So I had to keep feeling the pain. I can swim when I'm in pain. Yes. um, Sports and health service should not be only for rich people.
It is frustrating to not be able to access healthcare because of financial barriers. And I've heard that from other disabled people all over the world. That money is often a struggle.
Yes.
What do you think should be a solution? What should organizations do in Suriname to help people get access to healthcare?
Okay. In Suriname, people with disabilities like me found it hard to do everyday things. The government helps by giving us a small bit of money each month, about 90 euros. But signing up for this like solving a puzzle. Some people can figure it out, so they don't get any help. Next, even for those who do get the money, it's not enough to pay for everything. We we need like medicines and special exercises called physiotherapy. It's like trying to fill a big bucket with a tiny cup. Families of people with disabilities have to work really hard to pay for everything. They want to give their loved ones the best life, but it's very difficult. Yes.
Yeah, it's very very difficult. It sounds like, and in other places too, when there are supports for disabled people, often there's a lot of administrative bureaucracy that makes it difficult. And if you have an additional cognitive disability or you're facing barriers to even access those supports, that's a problem. So I want to ask, are there any final comments, advice, or stories you want to share?
Yes. We can do more together than we can do alone. Anyone needs to work together to help people with disabilities stay healthy. We all want to be happy, to be healthy and happy. It, it's important to listen to people with disabilities. We should be part of the talks about how to make things better. We should never make decisions about people's lives without talking to them first. Thank you.
I absolutely agree. We should all be listening to disabled people. Nothing about us without us. My assistant just gave me a secret message. Thank you for that. So, talking about listening to disabled people in Australia have been coming together to advocate for change. and it's been really moving to learn about what's happening in Australia. And today we're very lucky that Her Excellency, Ms. Natasha Smith, Australia's ambassador to Germany, is with us today. Ms. Smith, can you take the lectern?
Thank you very much, Haben, and can I thank the organisers for the opportunity to contribute to this important side event today. I have to say I'm both honoured and humbled to be part of this event. I'm not someone who is living with a disability, but I've worked on these issues in the past and feel very passionately about them as someone who's a background in development and human rights as well. The health inequities that are experienced by people with disabilities are stark, and they're as stark in countries like Australia as they are anywhere else. We know that people with disabilities have difficulty accessing health services that meet their needs and support them to lead healthy and fulfilled lives. And that the unfair conditions people with disabilities experience throughout life mean they often experience poorer health outcomes compared to people without disabilities. The WHO Global Report, as Jerome has shared with us, really highlights these inequities and frankly calls on all WHO member states to take action to advance health equity for people with disabilities. It emphasises the need for political leadership, for adequate resourcing, and most importantly, to work together with people with disabilities. As you say, Haben, nothing about us without us. I want to share very quickly some of the examples of what we're doing in Australia to answer that call, both domestically but also in our support for other countries and the political leadership in other places. We're proud of the steps we've taken to invest in good policies and programs that address the factors that contribute to health disparities. Firstly, through Australia's Disability Strategy 2021 to 2031, where the government has really recognised the importance of ensuring that all health service providers have the capabilities to meet the needs of people with disability. And importantly, that people with disability are empowered and are able to make their own decisions about their own health. This was developed in consultation with people with disability, and the strategy reflects our commitments under the United Nations Convention on the Rights of Persons with Disabilities, commitments we take very seriously. We're also focused on addressing the serious health inequities faced by people with intellectual disability through our national roadmap for improving the health of people with intellectual disability, which was released in 2021. Priority actions underway include improving the knowledge and skills of health professionals to be able to provide high-quality health care. Often it's not that health providers don't want to, it's that they don't know how to, and that's an important role that government can play to help with. We're also now working on a new national autism strategy, which will be released next year. Disability rights, as I said, is something that we're very focused on and committed to domestically, but also an integral part of Australia's international engagement, including our engagement on health. As highlighted in our International Development Policy, which was released last year, Australia is committed to advancing the rights of people with disability, to prioritising prioritising disability equity as a core priority for action in our aid program. We're also developing a new international disability equity and rights strategy, which will contribute to the outcomes of our overarching international development strategy. It will replace the Development for All program or strategy that we've had since 2015. We've been very proud to be a leader in this space internationally. The first Australian International Development Disability Strategy was actually released in 2009. But it doesn't mean that the job is done by any means, and there's so much more for us to do. We're working throughout our region to support our partner governments to progress health equity for persons with disabilities. We have provided support to the Fiji government, for instance, as they've developed and are implementing their National Disability for Inclusive Health and Rehabilitation Action Plan. We've also supported this policy and action plan through practical partnerships that look at how to empower and enable people with disability to access health services. I'm getting the wind up, so I'm going to go faster, sorry. I have to, especially with Ibu Venzia here with us, also note that we have, through our Australia-Indonesia Health Security Partnership, supported disability-inclusive approaches to vaccinations during COVID-19. And one of the outcomes of that wasn't just making sure that vaccinations were provided to people with disability, but it's actually led to an improved recognition amongst local governments in Indonesia for the need for inclusive public services and for the enactment of provincial regulations for disability inclusion. So we're committed to ensuring, I'm going as fast as I can, 30 seconds, we're committed to ensuring that all of our health partnerships, our whole international development program, as well as our domestic services are inclusive of for people with disabilities. And we're committed also that to the global leadership and multilateral action in this space as well, through our co-chairing of the Inclusive Health Working Group in GLAD, the Global Action on Disability Network, and our ongoing commitment and work through the Committee on the Rights of People with Disability, and our partnership with WHO, including through the International Disability Alliance. There's more to be done, lots more to be done, but this panel is a really good example of how the disability inclusion is now really becoming part of the health discussion broadly through the World Health Summit. Thank you.
Thank you, Ambassador Smith. We have a panel that's coming up next. And on this panel, we have from Nigeria, Helen. Let me do this. Helen, can you introduce yourself?
Hello, everyone. My name is Helen Hanurika Beyoko Alashe. I am a deaf woman. I became deaf at 1994. And what caused this deafness? Just one morning, I went to school, came back, and had a little fever. I felt feverish, and then my mom took me to the hospital. At the time, there was no cell phones, and the doctors and nurses just gave me an injection, and then that injection led me to the world of silence until this day. And that did not stop me from progressing in life. I enrolled in a deaf school, Lance the Sign Language, and this is just my deaf history. Thank you.
Thank you, Helen, and I apologize for struggling with your last name. So Helen is also Executive Director of Deaf Women Aloud Initiative. And I want to ask Helen, what are some of the challenges facing deaf women when it comes to access to healthcare?
Thank you very much for the question. To start with the challenges, we have legislations about disability. We have the universal health coverage, which talks about everyone having access to health services regardless of the status, regardless of the race or disability, have access to quality health services without any financial hardship. Also, we see situations where we have other legislations like the UNCRPD, the other protocols that are readily available, and also, yes, the African Protocol on Disability. We have articles there that stipulates about health equity and access for persons with disabilities. Also, we talk about the Sustainable Development Goals. All these recognizes the need of health for persons with disabilities. Now, for me as a deaf woman, having access to health services or equity for persons with disabilities is actually a challenge, especially when it comes to the models of disability for which health professionals, approach us. Most times when we go access health services, they tend to look more on the impairment or disability rather than what actually is the reason for, such visits. So the attitude is actually a huge barrier, attitude of healthcare workers towards persons with disabilities who are seeking for healthcare. And 12 years ago, I went to the hospital for my antenatal care when I was pregnant. And deaf women also have access to healthcare. Do you agree with me? So so I went to the hospital very early, just like everyone. And in the data collection form, there's nowhere for you to feel you have a disability or no disability. So just like everyone, we're just sitting, waiting for the healthcare workers to come. So numbers would have to be distributed to everyone to come in according to your own number. But I was there, and no one was able to attend to me. There's no form of identification of if you have a disability or if there's special accommodation to be given to you. So it was really frustrating. So the communication at the hospital was a challenge. There were no sign language interpreters to explain to me what was going on. So the stigma that you see there at the hospitals, and due to this, it becomes very difficult for deaf women to follow truly with what is happening. Then we'll talk about equipment and the assistive technology in terms of trying to take the weight of measure of pregnant women who are on wheelchairs. The challenge is there. And when you try to, a doctor will try to diagnose to know exactly what actually is issue, the lack of communication most times make the doctors to misdiagnose. And, most of this leads to serious health conditions that actually affect women. Deaf women get married, persons with disabilities get married, and also we raise families too. So talking about antenatal services, the type of quality for which access to contraception, for instance, because of the SRHR needs for all. So we do not have opportunity to make the right choices. Most times they just assume this would be this model of this would be okay for you. Just assume that would be perfect for you to go for maybe contraceptions or stuff like that. So most times our body systems are different, and most of them, when these decisions are made on behalf of women with disabilities, it actually affects them. So these are just a list of few of the challenges we face. Thank you.
Thank you, Helen. And also we have from the International Disability Alliance, Jared Klein, the Deputy Executive Director. And I want to ask Jared, what are some of the challenges to healthcare facing people with disabilities?
Thank you, Helen. Firstly, I'd like to acknowledge that it's a very diverse population, right? So the experience of a deafblind woman in Eritrea or California is very different. In Suriname, there's difference in diversity across impairment type. So that means that the response also needs to be individualized while also addressing systemic barriers. I think that clearly the common experience, though, is of exclusion and marginalization in health systems and society more broadly. And that's the key question that we're wrestling with today and I guess for many years to come. Historically, at best, governments have focused on prevention or rehabilitation or assistive technology, but not tended to look at health systems so holistically, and that is a major challenge and a major problem. That's not to say, of course, that prevention policy is not legitimate, or that rehabilitation and AT is not a very essential issue. AT helps unlock the everyday. Rehab, there's a huge unmet demand for rehab as well. So those are all important, but we also have to look at the bigger picture, and that's to consider the issue of health equity for persons with disabilities. I think that if we ask questions, and they're all thoroughly in the amazing WHO global report, what are the rates of NCDs of persons with disabilities compared to others? Are women with disabilities getting accessible and quality reproductive healthcare services or not? Are children with disabilities being immunized at the same rate as others? Are people with psychosocial disabilities receiving cancer screening at the same rates of others, or are there still barriers for all of those services? I think the answer is clear if we look at all the evidence that there is a considerable gap in that equity, and that's for many different interrelated reasons, but we have to acknowledge also that there are legal barriers. Many people with disabilities are not allowed to make decisions for themselves. That's a huge barrier. There's inaccessible information for various reasons, whether it be because you're deaf and you can't communicate with the doctor, or the information is not an easy read for persons with intellectual disabilities. There's physical inaccessibility. Attitudes of health workers, as we've heard, discourage people with disabilities from seeking health treatment. And we also have to say, as mentioned in Suriname context, that affordability is a huge one, is a huge factor. And this brings us to issues like the underlying and social determinants of health. Persons with disabilities have very little political power. They are excluded from education and employment. They have less money than other people, so they can afford less services, and often those costs are not socialized, right? They're imposed on the individual. So clearly, there are really significant systemic challenges and barriers, and the response also has to be systemic, and that's what's been missing. We need to reframe our expectations of what health systems can and must deliver for persons with disabilities, particularly those with higher support needs. And additionally, we do need stronger political commitment. Australia is probably the leading country in the world in having a very coherent approach, both domestically and in the context of international cooperation, but that's surprisingly rare. We also have a lot of positive language about involvement of persons with disabilities through their representative organisations, but actually integrating organisations of persons with disabilities in policy design, monitoring and implementation is also very rare. So there are lots of things that can be done. I guess that's quite a big list. But at the same time, what we didn't have before the global report a year and a half ago or 2 years ago was the right framing, the right narrative. So we understand what we need to do. It is reduce the health equity gap for persons with disabilities. We now have guidance from the WHO on how to do it. We have 40 recommendations. They're producing a guide to action and have a platform. So all of the constituent elements in theory should be in place, but really conscious that all of that is still just words on paper until we have the national level action, and we can be inspired by examples like Australia and the US and other places and learn a lot from good progress, but it's a shared challenge and a shared responsibility. Thank you.
We have such different situations around the world, but studying some of the solutions that each community has can help give ideas for what other communities can do to address these challenges. So I want to ask Helen and Jared if you can share 2 action steps that advocates and health organizations can take to address the health challenges people with disabilities are facing. So let's start with Helen and then Jared. What are 2 recommendations you can share?
Thank you very much for the question again. So as you know, we have various provisions and implementation. We have different policies and legislations. Challenge is always on implementation. So I think, first of all, we would want to have ownership of most of the interventions that different organizations like NGOs are bringing up. When government decides to own these projects, these laudable projects, and adopt them afterwards, that would to a large extent solve. Example, we had thanks to the Australian government, there was a project they funded in Nigeria which ensured having sign language interpreters in hospitals. Now that project ensured sign language interpreters to be provided in selected hospitals, but at the end of that project, the service ended. If the government had actually gone ahead to adopt such project, it would have gone ahead and to be sustained up till now. So that's issue of ownership. Then we also have, when government decides to own these projects and continue with them, that is, when we talk about sustainability, it goes on that. The second I'd like to recommend would be on being intentional. It is very important for us to be intentional in developing projects or developing ideas, policies that, having that intentionality to ensure persons with disabilities are carried along and their health needs are duly taken care of. It could be in forms of budgetary allocation, increased budgetary allocation, or development of more project that will contribute to our health needs. So these two recommendations, ownership and intentionality, I think it will go a long way to create more access to healthcare needs of persons with disabilities, and to a large extent reduce the stigma and reduce the challenge that we experience in the field. So we need to show commitment and continue to help us to have access to healthcare services. Thank you so much.
And I'll answer now, if that's okay, Harbin. So on my side, I would highlight also two things. That is, the first is participation, and the second is accountability. And they both relate to each other. But on participation, I mean, in the health sector, of course, the issues that arise are quite individual. So that's why often collective action through organizations of persons with disabilities, which provide a representative function and to take account of the diversity of experiences of persons with disabilities, can be very useful. And that institutional support can also play a leading role in designing policies and providing feedback and in monitoring. And also on accountability, I mean, this can take various forms. Of course, legally, strictly, we rather hope that with the CIPD and ratification and then regular reviews, this would lead to long-lasting societal transformation in all sectors, including the health sector. If we're being really honest, we haven't seen it so far in the last 15 years, so we need to reflect on that. But whatever form that accountability can take, whether legal or political, and it needs to rely, of course, also on the data side as well. We need to think how we can measure the inequity gap and then address it. And without that accountability, we'll have probably empty promises for another 15 years. But and just finally, while I have the floor, I think that the key point is that looking at the broader inequalities, the historically accumulated inequalities have deadly consequences, and we saw that during COVID, but even afterwards, I guess maybe things haven't quite got to the place where they should. So I'm really hopeful that participation and accountability can be the next steps. Thanks.
We have brilliant expertise in our panels here, and this is your opportunity to ask them questions. So if you have a question, raise your hand, and Miriam will pass you the microphone.
Thank you, Harbin. We have a couple of hands, one in the front row. Do you want me to pass the microphone from this end? I can do so. Please introduce yourself and where you're from.
Thank you so much, everyone. My name is Paulina Hastenteufer, she, her. I'm here representing the Youth Health Organization, and I'm also myself chronically disabled. This is my second time at the World Health Summit, and last year there was not a single panel that talked about disability or the experience of disability in the healthcare system. And it was very frustrating as the first big international event to come here and to see that the people who are discussing what is relevant for me and for my daily life don't actually discuss it. And I was at the World Health Assembly this year as well, and I was the only person with a service dog, and most of the staff had no experience with how to deal with a service dog and even doubted it was mine because I don't look disabled. And I wanted to start by just saying a huge thank you for doing this. This means so much, and I'm close to tears for the whole time because seeing another person with a service dog being represented, but also just seeing people like me talking about our lives and our experiences just means a lot, because we've been here forever, and you either die young or you become disabled. This is not irrelevant. This is not a small part of the population. So thank you. And as for my question, I was wondering, because it is a question that I spend a lot of time with talking about the topic, it's the wording we use, because Haben, you use disabled. I also use the word and identify myself as a disabled person, not a person with a disability. because I think that I am not the problem. The lack of accommodation for me is the problem. Whereas the name of this panel and the wording that some people use is persons with disabilities, which implies that I am the problem, that I have something that needs to be fixed. But it is nothing that needs to be fixed. I am a valuable human the way I am. I just want to participate in society. And that needs accommodation. So I was wondering why each of you uses different language, especially if you don't choose disabled. And what is your view on the topic? Because I think the more it is coming up as a discussion topic in the global health sphere right now, we should address the proper wording we use, especially. Yeah, thank you.
Thank you so much for saying that. This is so important to be talking about health equity for us at the World Health Summit. And we should be having panels like this every year so that it becomes normal and everyone working in health thinks about disability. The language we use is different all over the world. And when we have international events like this, with people with different native languages, different sign languages, different cultural preferences, we start to notice how we talk about disability all differently. From the American disability perspective, many advocates are saying, you know, by 2024, we should know that disabled people are people. Do we really need to remind ourselves that these are people? Can we talk about it just the way we talk about women or other groups without having to remind ourselves over and over again that we are people? So some advocates are saying identity first language. Let's celebrate disability. We're not ashamed. We don't want to hide it. We want to be able to bring our full selves to medical school, to the hospital, to the health ministry, and get full respect. But I want to turn it over to our panel. Do you have thoughts you want to share on language, Helen or Jared?
Yes, Helen, thank you very much for the question. So truly, everyone have their ways they want to be identified. And what's most important there is, as we have different forms of disability, we also have different ways we wish to be addressed. For instance, myself, I am deaf. I am a deaf woman. Some people think if they use the word deaf that I will be offended. No, I am a deaf person with the word T. I'm a deaf woman. I'm a deaf person. And maybe you might see a blind person, and I say this is a blind person. Most others will feel offended I use the word blind. But for me, it does depend on what I wish to be called. For me, actually, personally, I don't want to address myself. Although we have internationally recognized terminologies to describe different forms of disability, however, it's all about ownership on what you want to be called or what you are comfortable. Some want to be called disabled. Some want to say persons living with disabilities. Some say the argument is I am not living with disability as a tenant. I am a person that has a condition of disability. So there are different things. So I feel is what makes you proud, you own it, and that way, I guess. So for me, I don't feel discriminated when you call me deaf. I identify with that, and that makes me proud. Thank you very much.
And then to that, I would just add that I think that the term persons with disabilities is used in international meetings because it comes from the convention, it comes from the CRPD, which, of course, embodies and enshrines the social model of disability. So certainly in international context, it's not understood to be stigmatizing or to be impairment focused, and the idea of fixing society is at the core of the CRPD. For myself, my background is from the movement of persons with psychosocial disabilities. there aren't many persons with psychosocial disabilities who even really like that term particularly. Many prefer users and survivors of psychiatry, which is a phrase I'm not sure is super welcome in a World Health Summit, but all the better for me having said it. But I just want to recognise that national contexts inform the language, and it's important that the language is used that does reflect the right approach, which is a rights-based one. So I fully support everyone's choice of language. In New Zealand, it's people with disabilities. Persons can seem a bit clinical and legal, so I do acknowledge the deficiency of that.
Harbin, we're just asking a follow-up question on this. Please go ahead.
Yes, thank you. Just as a clarification, because you said that persons with disability comes from the social model of disability, but as far as I understand it, the word person with disability comes rather from the medical model of disability more than the social, because persons with disability is the idea that the person does have something that needs to be changed. There's a medical difficulty, and that is why the person has a disability, whereas the social model of disability is the idea that I, as a person, I'm doing perfectly fine, and it is the society that is disabling me through its lack of accommodation, which goes to the term disabled person. So historically, I understand that it comes from the convention, but the convention already used wrong wording because it kind of addresses the social model but uses medical model language.
I mean, it's an interesting critique. It's not. I've heard it before from people in the UK. I think everyone's interpretation is valid in a sense, but I mean, I think that we should know that there's not even a definition in the CRPD, right? It's a bit awkward and it's not ideal. I think the general comments and the views of the committee kind of clear it up in a positive way. So take your point. Thanks.
Thank you. So we have a lot of questions, Harbin, in the room, but unfortunately at this point only time for one more. So please, those people who want a question, hold it with you. We'll do one more question and then we'll move to the next panel. Thank you. Please go ahead.
Thank you very much. My name is Dr. Arman Siddiqui. I'm from Bangladesh, and I am representing Grameen Digital Healthcare Solution, which is actually dreamt by Professor Yunus. We are working towards offering 15 cents video consultancy of healthcare, and we have already done it. I'm so much inspired to actually join this session, and I was just wondering like how fast we can actually have this disable communication at least for the digital healthcare solution. I mean, I can foresee a lot of apps out there for sign languages, but if we can launch it multi-language, and then in our country, people cannot get even a normal healthcare service. So this is a long tail vision, but still we really want to address the digital divide and make it happen. Gerald, you can shed some light if there is any roadmap for international community to actually offer them a digital healthcare solution. Thank you.
I mean, there are WHO ITU standards. I'm not sure what that means in terms of quick rollout. I guess that's acknowledging that there is a need for some standards to be met, having things standardized. On how fast, I mean, that's a very technical question beyond my expertise, hopefully sooner rather than later, and I'm sure the people at AT Scale are probably working on that and involved in that, so can maybe answer more. Or Kalyan. No.
All right, can we get a round of applause for our panelists? And can panel 2 come and take your seats? So this second panel is about finance. Many of these projects, digital healthcare, sign language interpreters, require money. So in our second panel, we'll be exploring how do we get access to that money. And this second panel also has Helen with us still. And we have from Indonesia, Dr. R. Vincia Situang. And we also have from Ecuador, the Honorable Maria Jose Plaza. And I want to ask, how do you get access to funding for disabled people to ensure that we get access to healthcare? Can you share some of the strategies you found? And maybe let's start with Dr. Situang and then go down the table.
Asking here. Sure. It's possible to yes. Okay. Thank you, Heaven. It's a pleasure
I'll
to be
repeat the
present.
question, no problem. No rush. We can take as long as we need. So, finance. How do we get access to money so that we can make sure healthcare is accessible to disabled people? And I want to ask all of you to think of examples of how we get access to funding. And we will start with Dr. Situang and then go down the table.
Yes, thank you, Heaven. It's a pleasure to be present in this room with this very interesting and noble topic, I think. It's very touching that people with disabilities have advantage and they also have to be empowered like other else. Okay, answering the question in our country, Indonesia, that based on Indonesia Health Survey 2023, approximately 1.4 of the population in Indonesia are persons with disabilities. Person with disability already defined in our law since 2016 as every person who have physical, intellectual, mental, and or sensory limitation for a long period may encounter barriers and difficulties in interacting with the environment, which can hinder their full and effective participation alongside other citizens based on equal right. The situation is out of 289 outpatient in Indonesia case-based group codes, 28 related to the care needs of individuals with mental, physical, sensory, and intellectual disabilities. Additionally, 112 of the almost 800 inpatient Indonesia care-based group codes address these needs that cover by national insurance. And actually more than 80% of individuals with disabilities have national insurance. It's estimated that over 94% of individuals with disabilities utilize national insurance for their treatment and in health services, because they understand the benefit of the national insurance for their medical needs, like Rachel and Helen's mentioned and her experience also. Fortunately, now 7 types of assistive devices are covered national insurance benefit packages. Claim for assistive device has increased over the past 3 years. Out of 1.4 million cases utilize assistive devices, about 1.3 million are for glasses. The other side, currently we are also conducting various studies to promote and the expanded use of national insurance in covering assistive technology. And the second one, currently we also being drafted in the Minister of Health Regulation on health efforts include health services for people with disabilities. The Minister of Finance is drafting a government regulation on concession and incentives for individuals with disabilities, which includes incentive and concession for healthcare services, including health aids, assistive technology. So there are the steps Indonesia government has taken to address the financial challenges that people with disability face in accessing health services. Thank you.
Well,
Helen, can you go ahead?
Please, can you come again with the question?
I can answer now if you want.
Absolutely. So the question is, what strategies have you found to get access to funding so you can have projects to help deaf women or other disabled people get access to health care? How do you get access to funding?
Thank you very much, Ellen speaking. When we talk about funding, funding is about ensuring that we have access to a system that designs finance allocation for persons with disability, and in this way it's very difficult. In our country, in Nigeria, we do not have a good system where we have access to funds. When it comes to accessing healthcare facilities, in Nigeria, most times, persons with disability are the ones who use their personal money to pay sign language interpreters or their aides in assisting them into the healthcare facilities. And then report shows that persons with disability are the poorest of the poor. And most times, they do not have opportunity to get better employment, have better businesses. And with the little change that they make, is still what they make use to pay for sign language interpreters, in accessing healthcare services. And then back home, most of there's what we call health insurance, and health insurance doesn't really cover all of our needs. It doesn't even cover 50%. So we still get to spend more from our pocket. And you can imagine someone who earns a very little amount of money, finds it very hard to feed, not to talk of transportation to the healthcare centers. And then I would still have to take from that little money and pay a sign language interpreter, all because I need services in the healthcare centers. This means that access to funds is not accessible, most especially from the government, and the opportunities are not there. And persons who are not disabled, they have access to more opportunities than persons with disability do, and the problem is double. Now, in Nigeria, we have 1,000 naira note, and when we want to pay for a service, we get to pay double the amount than usual. So these are the challenges that we face as a deaf person, and because we do not have a standard system that gives waivers for persons with disability. Thank you.
It's frustrating when we don't have access to funding and end up having to pay more than non-disabled people. I think members of parliament can be allies in trying to increase access to these resources. And Maria, you were a member of parliament in Ecuador. What's the best way for us to work with members of parliament to increase access to health care for disabled people?
Thank you, Heben. Well, I think that the best way is to try to work with social entities and with ONGs to help funding, because in Parliament we can check the national budget for health and for disabilities, but we don't have much control of how much is given for disabilities and for the rest of the people of the country. In Ecuador, health is considered a right, and health is free for every citizen in Ecuador. And still, we have problems of getting those funds for the people in need. We still have many problems especially with disabilities, even though we have our organization that we created in Congress called CONADIS the National Council of Disabilities, that plays a crucial role in collaboration with various ministries to promote and fund disability inclusion initiatives. It helps develop policies and programs that ensure the integration of individuals and disabilities across sectors, including education, employment, and health. By providing technical support and resources, it enables other ministries to implement effective strategies for inclusive practices, ensuring that funding is allocated appropriately to meet the needs of people with disabilities. But I still think there's a lot more we can do. Thank you.
So I have to agree that there is so much more that we could be doing. And I want to learn what more we could be doing. So a lot of people here are here for ideas and action steps. Can you all share one more action step for securing funding for different disability projects?
It's me? Yes, agreed that health equity is a buzzword. Yeah. Based on existing regulation in our law and government regulation, a person with disabilities have various rights, including the right to health and access to quality healthcare services. Currently, it is estimated that there are 3,000 primary healthcare, like in Puskesmas, that have achieved full accreditation. Fully accredited health center must at least be able to identify barriers faced by persons with disabilities, arrange space accordingly, and ensure ease, safety, and comfort to access. Therefore, it is essential to enhance the communication skills of healthcare personnel. It is necessary that health workers must have a positive attitude and be able to interact and communicate according to the different types of disabilities, like sign language in this room, communicate with movement. Most health centers face challenges in both facilities and human resources to provide healthcare services in an inclusive care for persons with disabilities. But at some local level, there are best practices such as in Bandung, East Java, with its inclusive services. In other local level like Balikpapan, Sukoharjo, and Surakarta, with therapy services for children as well as at the community level. And the current situation, we are drafting a Minister of Health regulation on health efforts that includes regulation for the health of persons with disabilities using a life cycle approach with promotive, preventive, curative, and rehabilitative, and also palliative efforts, as well as improving skills and standards. And the other one, developing a master plan for health 2025-2029, which will serve as a guideline for ministries, agencies, and local governments in their planning and activities. This plan includes targets related to the healthcare services for people with disabilities. And drafting long-term and medium-term plans 2025-2029, and the health strategic plan of the Ministry of Health also emphasize various targets to enhance healthcare services and accessibility for people with disabilities. The last one, earlier you mentioned supported WHO. Yes, but we are currently preparing capacities assessment and developing strategies to achieve health service global goals for disabilities according to inclusive standard. And now we currently are continue. The result of this preparation will be implemented to access and drafting the healthcare for people with disabilities roadmap in 2025. But I think our government have a commitment to achieve health equity for persons with disabilities. In fact, the Indonesia government has taken quite a lot of steps to find financial solution to make it easier for people with disabilities to access health services. Thank you, Haben, for being a guiding light.
Maybe engaging with civil society organizations and international partners could help advocate for the necessary reforms and funding to improve accessibility to quality for care for persons with disability. And I think we have to do that fast.
Thank you again for this. So from my personal experience, I'm going to use the Nigerian perspective now. Provision of equal opportunity for all. Once you provide this opportunity for persons with disability, then they are able to access the resources needed for their healthcare needs and services, and also to subsidize assistive technology. Like in the US, we have the cochlear implants for the deaf, which cost about $10,000. But with health insurance, the persons have to only pay about $1,000 or thereabout. So we would love that the Nigerian government adapts this method and implement it in the country so that it will be much easier for persons with disability and deaf persons to access affordable healthcare services. Like I said earlier before, I go to the hospital with my own responsibility to pay the sign language interpreters. And also, as persons with disability, they go with their aides, and they have to pay for it. So it would be so good that the government tend to subsidize this transportation cost as well. And also, we would also want the government to also reduce transportation costs, because persons with disability, especially the ones who make use of the wheelchair, would have to pay for two, which is paying for the wheelchair and also for themselves. So if the government can actually intervene in this, it would go a long way for us. And also, persons with disability should always be involved from the beginning plan, from the starting stage to the design stage, because they tend to be the one to know where the shoe fits, and they have to speak for themselves so that they can give the right needs and expectations. And also, most times in Nigeria, there should be budgeting and allocation, most especially more finance allocation given to persons with disability, so that these resources will be used to meet the needs for persons with disability and access healthcare services. The government can say, okay, we are going to give 20% allocation to persons with disability, so that things will be much more affordable for persons with disability. Most times in Nigeria, we have beautiful laws, we have beautiful policies, but the problem is implementation. So what we want right now is implementation of these policies, and I believe that if this is done, the systems will be good for persons with disability, and this would meet our needs. And I believe that, okay, the Nigerian government will make these things much more better and easier for us. Thank you.
We have another Q&A now. So if you want to ask our speakers a question, raise your hand and Miriam will pass you the mic.
Thank you, Haben. This is Juliet. So I'm going to be a bit more efficient this time. We're going to take 3 questions and then go to the panelists. But if you wouldn't mind trying to be brief, I know it's an important questions that we're asking. So would you mind taking 2 people from over there? That would be great. Thank you. And then we'll come over to this side. Thank you.
Hi, my name is Smita Sadasivan. I am from India, from Disability Rights India Foundation, and also a WHS Council member. I would like to know from the WHO representative here, like how many WHO office country offices have engaged persons with disabilities in their offices and worked out a health strategy for persons with disabilities, and what are they doing about it, number one. And number two, if the Australian government official can say like whether people with disabilities are enrolled and included in the health ministry, in the health department, in key roles, so that inclusion is really enhanced based on the UN's inclusion strategy, and also the community participation is ensured. Thank you.
Thank you, Smitha. That's great. Thank you. Let's take another question that side. Stand up if you can do so. That would be great. Thank you. So, Cameron.
Thank you very much to the panelists. And my name is Israel Adekunle Balogun. I'm a person with disability myself, a medical doctor, and also currently a PhD student at University College London. I've had the challenges, but my question is this: what can WHO do and other stakeholders do to speed up the process of addressing health inequality, especially in developing countries, where the burdens of disability is at the highest? 80% of the global population with disability are actually in developing low and middle income countries. Unfortunately, the global north have the resources to take care of their persons with disability compared to where the need is. That would be my question to the panel, and I want to hear from other stakeholders. Thank you so much.
Thank you, Israel. That's great. And on this side, sorry, please remind me. Thank you. Please go ahead.
Thank you. Thank you for the session and discussion. My name is Alexandra. I come from Ukraine, and here I'm representing International Federation of Medical Students Associations. And my question is basically, what can medical student associations and medical universities do in order to make sure that education is equipping young medical staff to meet the needs of the people with the disabilities? Thank you.
Over to you, Harbin, and the guests. We had a couple of questions for WHO there, so we might need to.
So I want to pass this to the panelists. Do any of you want to try these questions?
Well, I'm going to answer there. I'm going to talk about Ecuador. Active participation of people with disabilities in society is encouraged through initiatives that provide platforms for their voice and representation in decision making. We're doing lots of progressions for all these challenges, but the challenges still persist. So your answer was what we can do. We have lots of laws. We have made, like my colleague in the panel said, we have lots of laws that help and that are really nice laws, but why are they not being implemented? They have to evolve, focusing on improving social inclusion, accessibility, and overall quality of life for people with disabilities. And we have to work with civil society and international organizations. I see that's the only way, especially for us that we are in developing countries, South America, Africa, Asia, and we need to work with them so we will be able to make the laws that we have in our countries work for people with disabilities and for everybody, for marginalized people, for indigenous people, because laws are not enough. We have nice laws, but they're not working, and we have to make them work.
Okay.
Apologies, the ambassador would like to respond to some of this as well.
Thank you. Sorry, I think there was a specific question for me in there about whether people with disability are in our Department of Health. I can't give you the exact numbers, and I have much more direct experience of our Department of Foreign Affairs and Trade. but it's certainly across all our federal government agencies. There are people with disability at all levels, and we actually have some of our recruitment processes are very specifically for attracting people with disabilities and also for First Nations Australians. So we have special measures processes because we are committed to having our federal government organisations look like and represent the Australian community. And of course the Australian community is made up with people from a whole range of backgrounds and abilities, and so that is something we're doing very directly as a way to, I suppose, walk our talk.
We do need more agencies to measure the number of disabled people we're working with. If we're not measuring things, it's hard to know what's happening. And disabled people matter, our health matters. So we would love for the WHO to do more measurements on the disability population, what's changing, what's happening. And ministries and other organizations should also be measuring how many disabled people are you hiring? What percentage of disabled people are getting into medical school? This matters for all of us. Can we get a round of applause for our panelists?
So Helen wants
So Jared Klein from the International Disability Alliance. Helen, yes.
Thank you. I wanted to respond to the question from the Medical Students Federation. I think you mentioned medical students and universities play a huge role in ensuring that disability equity to healthcare is actually achieved. I think we could start from the curriculum, having things that have to do with attitudes or disability studies to be included. Perhaps that could help health workers introduce that into the curriculum or studies in both at the medical school, at least to have a basic understanding and background about disability during the practice. So when we introduce disability right in the curriculum, right from school, when they get out into practice, I don't think it would be a challenge. You see about that will lead to reduction in stigma and reduction to other challenge that persons with disabilities face when they go to hospitals. Thank you so much.
Thank you. I understand we have time for one more question, so we're going to take it in the room. So I went to the front row a bit, so let me give some equity to the back row. Is it possible for the lady with her hand up to have a microphone? Please stand up so that we can...
Thank you. Hi, I'm a East Asian woman, early 30s, and I have a ponytail. I have a white shirt and a black and white vest on. Thank you for the discussion. It was really helpful for me. I'm from Global Health 50/50, and we are trying to launch a report measuring and also looking into policies, how organizations working in the global health field are working on inclusion policies and how disability justice is implemented in workplace. So in this sense, it was very helpful to listen to all the questions and the answers today. My question is, since Helen was also mentioning about the importance of implementation, for you all, what do you think is important for the implementation of disability justice at workplace? And also my second question related to disability justice at workplace is, I do think it's sometimes very difficult to identify identify the disability components or disability at workplace. So how should this be accommodated from a policy perspective and also at the workplace or school perspective? Thank you.
Thank you. That's the end of the questions for this session. Please, back to you, Haben.
So, Helen or anyone else from the panel want to answer?
Thank you so much for the question. So we have different access to health. We have also access to justice, remember. So based on my work on access to justice, also, which it has a lot of resources which is needed, and it has to do with having access, justice systems that are accessible also, and having the right structures, perspective to be able to have, for persons also to seek justice, and for them to, be able to fight for their rights when they feel discriminated against. Also, just like we have in the medical challenges, when it comes to justice, it's the same there, trying to get an attorney or stuff like, or other challenges that will assess access to justice to be equitable and just. So we have most times percentage of funding that has to do with pursuing or fighting for justice to be taken care of or being off the direct spending or cost from persons' abilities. So I feel government also needs to also show the willingness and the will to implement and push for full implementation of the laws of accessibility, because when you look at the different protocols and laws we have, it's not just for health, it has other places where they are needed. So when we talk about implementation, it has to be multi-sectoral, and we just need that strong will to implement. And once that is done, the push, making priorities and being intentional also in most of these things. So for instance, when I want to implement, trying to monitor and see how effective most of the implementation process are going on, and see when things are not going correctly, how we can improve or move further. So I'm just giving an example based on my country, Nigeria, and to see if things are not going on. Yes, the law is there, but if it is not being implemented, is not carried out, there should be needs or things to promote there to and check if it's working or not. I don't know if that answers your question. Thank you so much.
Any more questions?
I just wanted to make just a simple thing, say something that we haven't addressed today, and I think it's very important to talk about mental health and the implementations of laws to help mental health. It's also a disability, a very important disability, and I'm thankful that I work on that on Parliament in Ecuador, and I was able to make the first law ever in my country for mental health. So that's what I wanted to get in.
Can I also add the information? Sure. Yes, I think at least when compiling the standard and regulation, especially in primary health care, we are together across all program and sectors, including people with disabilities and academia, including the medical faculty, of course, and the community, so that there is nothing that must be regulated that is not included in the rules, and various experience of people with disabilities. And also technology developments must also be included in the rules so that it can be implemented. And of course, it becomes a social control because we are both compiling and together monitoring and evaluating. So there is nothing that's not served. Thank you.
Thank you.
Thank you so much, everyone. I really appreciated sharing your wisdom and our excellent questions from the audience. So we have two more things. The next is an announcement about the Global Disability Summit that's happening next year, and Jared Klein is going to tell us about that.
Hubben, do you also want me to do a quick summary of the session, or is that not part of it? Either way is fine.
You could also do a quick summary of the session.
Okay, great. Okay, I'll be very great. Well, first of all, I mean, it's very important, this event, to have a disability-specific event in a mainstream health summit. It's a first and very hugely important. At the same time, we recognise that the disability movement itself needs to put greater focus and emphasis on health. There have been historical reasons why it's not been such a popular topic. We can lay the blame of someone else. But so at the Global Disability Health Summit in Berlin, the 2nd and 3rd of April 2025, health equity for persons with disabilities will be a major focus, one of the priority themes. And there'll be a pre-summit sometime earlier in the year as well. So we're hoping that those events will help drive commitments. We need political mobilization, we need resource mobilization, and we need really strong engagement from OPDs around the world. So we're hopeful that the Global Disability Summit will do that. Just to then very briefly summarize this excellent session, we heard a lot about diversity, diverse needs, the need for medical culture to change, the impact of health to advance social inclusion in Suriname, Nigeria, Indonesia, the role of social determinants of health, challenges in financing, recognizing that disability is a social construct, so the costs should be socialized, so government subsidies, AT provision, and the cost should not be borne by the individual. Additionally, the role of international cooperation is very important, and we also heard that there are lots of nice laws and frameworks, and I suppose we can add the WHO work to that, but it doesn't mean anything without the implementation. So we need the political prioritization, we need accountability, we need monitoring, we need to involve organizations of persons with disabilities, and we need access to justice. So that might seem like a lot, but I'd actually like to summarize it by stealing the words of Rachel from earlier on. And with 2 points that I think really could be the whole session. The first was we shouldn't make decisions without talking to persons with disabilities first. And the second was we can do more together. Thank you.
So before we all leave, I want to acknowledge that we have a really amazing group of people here. Not just our speakers, but all of you in the audience. And right after this, we have a coffee break. And I invite you to challenge yourselves to meet 2 new people and ask, what action are you going to take? We need all of you to take action. So start your homework now and meet 2 new people and ask them, what are you inspired to do? Enjoy the rest of the summit. Thank you, everyone.